Hello everybody, yes, I'm Dr. O. Today our lecture is about chronic renal failure. This lecture is the last lecture I will teach you. Hope you can learn knowledge from today's lecture. Okay, so let's go on. First, let's see the purpose and requirement, and you should master the definition of CKD, or CRF, classification, etiology, pathogenesis, and master clinical manifestation and the diagnosis principle, treatment principle. Okay. First, the definition of CKD. Today's lecture is about CRF, chronic renal failure, but I think CRF is advanced of CKD, but CKD now is defined as abnormalities of kidney, no matter structure or function, present for 3 weeks. 3 weeks. Oh no, 3 weeks. 3 months. Okay. Present for 3 months. Yes, we also call it chronic. Okay. Kidney disease. Yes, is abnormalities of kidney structure or function. So CRF is the advanced stage of CKD with disorder of metabolism and clinical manifestation. So in your mind now you should remember that the CKD is the early stage of CRF, and CRF is the advanced stage of CKD. So the basic definition you must master, always in your mind. Let's go on. Classification. So we always use a GFR, category. We also call it eGFR, estimated glomerular filtration rate. To divide 1, 2, 3, 4, 5. 5 stage. First, the first stage, more than 90, 90%, 90 milliliter minutes, per 1.73 square meters. Okay, the stage 2 is eGFR between 60 to 89. Only mild decreased. Stage 3 is 45. We also depart into 2 stage. 2 small stage. Stage 3A. Okay, 45 to 59, mild to moderately decreased, and stage 3B. 30 to 44, moderately to severely decreased, and stage 4. eGFR next 29 to 15, severely decreased, and the last stage 5, the eGFR here next 15. We also call it kidney failure. So today our lectures always talk about the stage 3, 4, 5. Always in here. Next, eGFR next 60. 60. Let's see the prevalence. In CKD, chronic kidney disease, in America, in 2011, 15.1% in America. 2012, the CKD prevalence in China is 10%, 10.8%. I think it's very higher. It's very higher now in China. How about your country? You can to study the article or study the clinical research. This picture illustrates the CCR, creatinine create rate. Okay, the manifestation we can see here. In your diagnosis textbook, always tell you that when the patient have EGFR or called CCR more than here, more than 50, more than 75 or 100. There is no symptom, asymptomatic. But if EGFR next here, next 30, next 30, we call it exothermic stage. Left 25 here, we call it renal failure stage, and next 15 or 10 milliliter per minute, we call it uremia stage. This stage divide into based on the serum creatinine. Creatinine. So I think the serum creatinine is more need for our clinical practice to determine the patient whether or not have a kidney injured. Okay, let's say the etiology. So many, in China, so many disease can cause the chronic renal failure or CKD. In China now, the main disease caused the CRF is chronic glomerulonephritis. The next lecture I will tell you. Glomerular disease includes so many diseases, but here IgA nephropathy is the most common of this chronic glomerulonephritis. Okay, and in European or country or America, Canada, maybe some other countries, diabetic nephropathy is the most common etiology of CRF. Sometimes hypertensive nephropathy is also common. This picture illustrates there are so many polycystic capsule here, so many, kidney. This is also another etiology. Then here we can see the other picture show here, the so many, maybe here, here, bladder, ureter, or kidney. There's so many stolen, in the urinary tract system. So we call it obstructive nephropathy, especially in our city, Guilin or Guangxi province. So many patients will have this etiology. Sometimes the female, like the nephrotic syndrome, SLE also can cause the CRF. So different etiology have different manifestation. So first you should in your mind what etiology, what causes the CRF, like the nephrotic syndrome. Okay, Then let's see the pathogenesis. No matter what etiology caused the destroy of nephron, then more normal nephron loss. Like here, renal failure, exothermia, 75% or more nephron loss. Then the body, decompensation of renal function. Then the patient will have renal failure. This is the basic pathogenesis of kidney failure. Then another pathogenesis is trade-off hypothesis. For example, when EGFR decrease, then something for example phosphorus higher, and then the body want to make these things normal. Okay, then the PTH, this hormone, PTH, higher. Now, with the excretion increase, want to change the phosphorus to be normal, then PTH is higher, abnormal here. Okay, so another some pathogenesis also existent. Here hyperperfusion, hypertension, hyperfiltration, and sometimes tubular interstitial fibrosis, like last lecture I tell you. Chronic interstitial nephritis, also can cause the CRF. Here is the most important part of today's lecture, the clinical manifestation. So, when you see one patient in front of you, you should know how to know to determine the patient whether or not have CRF. Okay, here first let's say here water, electrolyte, and acid-base imbalance. Yeah, sodium water imbalance. Yeah, this is the most common happen in CRF. Potassium imbalance. Yeah, sometimes metabolic acidosis, calcium phosphorus imbalance. Yeah, so many electrolytes and acid-base imbalance happen in chronic renal failure. Then let's say the whole body, every system will injured in this disease. First, cardiovascular system, here the patient will have hypertension. Sometimes, with the more time, the patient have the hypertension not control. Here in these pictures, the cardiovascular disease happen left ventricular. Here. Left ventricular hypertrophy, yes. Sometimes vascular calcification, for example, atherosclerosis, like here, like in these pictures. Sometimes it's heart failure, yes. Sometimes uremic cardiomyopathy, yes, also happen. And sometimes pericardial lesion, So many cardiovascular lesion can happen in CRF. Next, respiratory system. For example, like these pictures, sometimes we call it butterflies. What is butterflies? Yes, the left or right, the lungs is synthesities. Okay, so the pulmonary edema in urine is like butterfly wings. Sometimes the patient will have pulmonary edema, sometimes pneumonia. Sometimes happened. Digestive system. This symptom, always happen in the early age. So first is loss of appetite, and sometimes nausea and vomiting, sometimes gastrointestinal hemorrhage. Okay, like here, hemorrhage, always happen in CRF. Next, blood system. We know that the normal kidney function with some hormones, like here, hormones erythropoietin, erythropoietin, from the bone marrow produce red blood cells when the kidney function reduced. Okay, here, then the kidney unable to send as much as of the hormone to the bone marrow, then erythropoietin decrease, then the patient will have anemia. So the patient will feel fatigue all the time. Next, neurological and muscle system. Patient always have fatigue, insomnia, inattention, character change, sometimes depressed. Okay, muscle tremor or muscle spasm also happen. And renal osteodystrophy, sometimes happen with fibrous osteotitis and nephromalacia. Okay, sometimes osteoporosis. Okay, so many bone disease will happen in the CRF. So let's see the pathogenesis of this renal osteodystrophy here. Like here. When the kidney function decrease, phosphorus higher 125, oxygen 2 D3 decrease, then the calcium decrease. Okay, PTH, this is PTH, PTH parathyroid function increase, increase. Okay, then the bone have so many lesion, sometimes can we accelerate the anemia, vascular calcification. Okay, this is a basic pathogenesis of renal osteodystrophy. Next is the picture. Here, like the shoulder here. There's something happen here. Maybe osteoporosis. Okay, sometimes like here, loss of trabecular bone. Sometimes with here, so many other things. Deposited in the ankle, in the finger, so many change in the bone. So next, I think you must learn in your clinical practice if diagnostic principle. For step one, definite the patient is a chronic or acute renal failure. Then you should ask the patient the history. If the patient have the symptom more than 3 months, okay, maybe it's a chronic. But sometimes this is a basic. I think this is a basic you should know. Sometimes we should combine with the laboratory examination. For example, if the patient is a CRF, we always happen with anemia, hypocalcemia, hyperphosphatemia, PTH higher here. The size you should know the size of kidney. So you should ask the patient to have a ultrasound to determine the size of kidney. The step two is to diagnose what disease, what etiology caused the CRF. Sometimes, as I said, IgA nephropathy is most common in China. Diabetic nephropathy is most common in European, Canada, America. What etiology in your country? You should know here. The step three is when the patient have CRF, what factor acute aggravating factors will accelerate the kidney function? So you should find. I will show you here. Cause of renal function deterioration. The first is hypovolemia. Okay, sometimes infection, sometimes it's urinary tract obstruction, sometimes heart failure. Sometimes it's the drugs, okay, antibiotic, X-ray contrast agents. So many factors can cause the renal function deterioration. Okay, so you should I think remove them to protect the kidney function. Then let's see the prevention and treatment principle. I divide the fourth part. Okay, one is how to prevent them. Prevention. 2, nutrition therapy. 3, drug therapy. And 4, if the renal failure happened, what can we do to save the patient's life? Number 4, renal replacement therapy. Okay, let's go on. First, how to prevent and how to treat. The first is hypertension control. Blood pressure control is the recommended target is 130/80. This number is very important for every CRF patients. And sometimes if the serum creatinine next 300, you will use the ACI or ARB to delay the progress of the CRF. Sometimes if the patient is the diabetic nephropathy, you can use the insulin, injection insulin to control the glucose. Sometimes if the patient is the IgA nephropathy, we want to use some prednisone. Maybe sometimes we use some immune suppressive agents to reduce proteinuria. The target is less 0.5 gram per day. Okay, and other recommendation, you should ameliorate anemia, use EPO, and advise the patient no smoking. Regulate hyperlipidemia. The basic disease I emphasize here. The basic disease treatment is very important. How to understand it? For example, if the patient's the etiology of CRF is SLE, so you can use prednisone plus cyclophosphamide, the immune suppressed agents to treat or to control the SLE active. If the patient is a diabetic nephropathy, okay, like here, you should use the insulin to control the glucose and control hypertension. Use ACI or ARB drug to delay or stop the progression of CRF. So basic disease treatment is very important. Next, let's see the nutrition therapy. Okay, here I divide three parts: the protein, calorie, others. Yeah, first CKD. Yeah, 1 to 2 stage. Yeah, the protein diet is about 0.8 gram per kilogram per day. Is okay. If the patient is gets into stage 3. Yeah, it's always recognized. Yeah, the lower protein diet, for example 0.6 gram per kilogram per day plus alpha kino acid tablet. Yeah, this is a nutrition drug to help the patients to have a good protein diet, but seldom poisons to excrete from the body. And others, like here, if the patient have edema, hypertension, as renal as before, restrict salt and water intake. Okay, and if the patient have hyperkalemia, okay, you can use drug to recommend to eat hypokalemia diet. Okay, the patient is hyperphosphatemia. Yeah, you recommend the patient have a diet regimen contain phosphorus less 600 milligram per day. Okay. Complication treatment. Yes, as I said that before, there are so many complications: cardiovascular, water, electrolyte imbalance. There are so many complications happen in CRF. So first, you should know, if the patient have sodium and water imbalance, especially severe edema, you will recommend the patient restrict salt and water intake and use here. This drug is very common in our department. Furosemide 20 or sometimes 40 milligram 3 times per day. Okay, to relieve the edema and to help to excrete the more water and salty things. Okay. This is very common use. And second, if the patient have hyperkalemia, you can especially the serum potassium more than 6.5. Okay, this treatment regimen I think is most important for you. First, furosemide 40 milligram IV IV injection okay, and then 10% calcium gluconate 10 or 20 milliliter IV. Then the 3 is 5% sodium bicarbonate NaH3 CO3 125, or sometimes if you face the severe acidosis, I think metabolism disorder in this condition recommend 250 milliliter IV drip. Okay, the 4 is 50% glucose, for example 40 to 100 milliliter plus. Okay, insulin 6 to 12 units IV drip. And last, if you use this drug not control the sick or not to decrease the potassium, okay, you can use dialysis. Include blood dialysis or sometimes peritoneal dialysis. Okay, so if you face the metabolic acidosis, divide two parts of the patient is a mild acidosis, just oral sodium bicarbonate tablets 1 to 2 grams 3 times per day is okay. If the patient is a severe acidosis, okay, let's see the renal function examination, and then the total CO2, okay, less than 13.5. Okay, you can use 5% NaHCO3. Okay, 250 milliliter IV drip. I think is the response is very good. anemia treatment. Yeah, here if the patient hemoglobin less 100 gram per liter. Okay, you can use EPO. EPO doses is every kilogram used 80 to 120 units. Yes. Injection mode subcutaneous or intravenous injection is okay. Yes, there's no difference. Okay, the hemoglobin target is 110 to 120. Okay, this target is more suitable for every patient. Okay. Then if the patient have renal osteoporosis and so many years the renal osteoporosis disease. Okay, here like here, if the patient have hyperphosphatemia, first you should restriction of phosphorus, phosphorus intake, oral phosphorus binder, calcium acetate. Okay, if the patient is a hypocalcemia, oral, calcitriol, but use this drug, this drug, calcium acetate or calcitriol. You should monitor, calcium, phosphorus, and PTH, in about 1 to 2 months, 1 to 2 months. So the PTH target is pre-dialysis, certified to 110. If the patient is hemodialysis, IPTH between 115 to 300. Okay. So other medication you should notice. For example, if the patient etiology is a diabetic nephropathy, okay, like here, you should adjust the insulin dosage. Okay, why? So I will give you these questions. Why? Why the patient should decrease? Okay, decrease insulin doses. You can answer me why or 2 weeks later. Okay, I hope you can answer me. And another is if the patient have hyperuricemia. Okay, like here, very painful. You can use the allopurinol, to reduce the hyperuремia, to relieve the symptom. And sometimes the patient will feel a skin itch. Okay, very painful. Then you can use some antihistamines to relieve the symptom. So in China, as we know that so many Chinese traditional medicine, especially the herb medicine, so many Chinese traditional medicine in China to use to treat the CRF. But in my experience, I think the effect is very small. Very small. Why? Because the patients, as we know that the renal function, is decreased. So many Chinese herb medicines we cannot if you eat them every day. These drugs cannot to excrete from the body, so be careful of the Chinese traditional medicine. So next I will show you the renal replacement therapy. Here, this is the basic knowledge. If the patient serum creatinine more than 307 units or eGFR less 10 milliliter per minute, or maybe sometimes combined with the so severe uremic symptoms. For example, the patient will feel fatigue, nausea, and sometimes gastro or intestinal, hemorrhage. Okay, sometimes you should start the hemodialysis, or sometimes you can recommend the patient to receive peritoneal dialysis. And if the patient have one normal people donate their kidney to the patient, okay, renal transplant is also another very good treatment. So this picture I will show you, the basic, I think, basic principle of dialysis. The first picture, like here, the patient, there's a blood flows to the dialyzer. Okay, from here, This is the hemodialyzer, okay, machines. Okay, from this is this machine where filtering takes place here. Yes, and when they finish, wash the blood, then the blood from the machine tube into the body again. Okay, so this is hemodialysis. The right picture here is the peritoneal dialysis. Let's see here. This is the peritoneal cavity. This is a PD catheter. Catheter. We put the catheter into the abdominal. Then use the peritoneal exchange from here. This is the dialysis solution bag. You can put on it on a show, on the desk or some scale of things. Okay, but now you can the difference. Some student or some patient ask me what difference. This treatment you should go to hospital and every 2 or 3 times per week. But here, this treatment, peritoneal dialysis, you should receive this treatment every day and 3 times a day. So this is more difficult for patient. This is very easy for patient. And the economy of the two different dialysis in China now is the same. The patient just only pay for 10% of the whole fees of the dialysis. So in China, the government's policy is very good. Very good for the patients. So the patient can have a good time, good survivals. And this is a real clinical practice. This is the patient. Okay, then from the ning, and upper ning, from the blood from the body, into the tube, then go on here. This is the pump. Let the blood into the machine. Okay, then go on here. This is dialyzer. Okay, here exchange. There's so many poison, so many water into the dialyzer. Happens. Then there's some blood from the tube along the tube go back to the body. Okay, this is the real clinical practice of hemodialysis. Okay, so the next is the renal transplant. Okay, renal transplant. Now in our department or in our hospital, now we can't do this surgery. We have no priority to do this surgery, but we can know the principle of this surgery. First, this is a transplanted kidney from one normal people. Okay, from you can always put it on the left. Okay, the patient will only have one kidney and can have a normal life. So we can see here, use the transplanted kidney, then put the artery, vein, and then especially, put it this ureter into the primary bladder. Okay, then use this normal kidney. The patient will have a good survival. So, but in China now, there's very seldom. The people died from traffic accident, from other disease. They will not donate the kidney to the patient. So what a pity, what a regret. Okay, so hope that in the future the policy of donation will change it. Okay. So today, yeah, thank you for your attending. Today's we see the definition. We learned the definition. Yes, and we can see here the first picture slide. Yeah, we know. Yeah, we studied the definition of CKD of CRF. Okay, how to classification the 5 stage, and yeah, there are 6 or maybe more and more, and disease can cause CRF. You know, yeah. Yeah, IgA nephropathy, yeah, nephrotic syndrome, and diabetic nephropathy. Yeah, so many diseases can cause the CRF. And the basic, yeah, pathogenesis principle, yeah, you should remember in your, in your mind. And the most important is how to diagnose the CRF. For example, before that, you should know, yeah, the patient, yeah, will have what clinical manifestation, and the diagnosis principle. Yeah, what is the diagnosis principle? Step 1, step 2, and step 3. Okay, finally the treatment. Yeah, you should know the diet, how to control the salty food, how to eat the protein food, and you know that the most important is how to use the drug to prevent the kidney function decrease. Okay, so this is our today's lectures. Hope you can learn something from it. So 2 weeks later, I will chat with you in the WeChat group. Yeah, hope you can give me some good question about the chronic renal failure. Yeah, maybe in your, I think, in your country. I think now, so many diseases can cause the CRF. No matter what disease. So the most important for you, I think, is to how to find them, how to diagnose it in the early age stage. This is very very important for you. In your mind, if you learn, have time to go to my division or department. So hope you can see the symptom of these CRF patients. Whether or not have edema, whether or not have hypertension, or sometimes have cardiovascular disease or digestive disease. Yes, so many system cardio complication will happen. So many symptoms will happen in CRF. So this is very important, I think, for your final examination. We'll give you one case. Ask you, the patient will have octuria, okay, for 5 months, okay, more than 3 months. Then the patient will have proteinuria 2 plus or 3 plus, and with hematuria, and the serum creatinine is higher. So the question we always ask you, well, what's the etiology cause the CRF, and these patients, how to do you know how to diagnose the CRF, and then how to treat the patients. In the clinical practice, this is very important. If you know this patient is a CRF, so how to treat them is very important. For every doctor. So this is today's lectures. Hope you can learn something. So it's my honor. It's my honor to I think not to teach you. To communicate with you with some knowledge of nephrology. So no matter the early age, for example, the glomerular disease, for example, acute tract infection. So whether or not the patient will go into the advanced stage, for example, CRF. So in our department, I think if the policy is good, so I think the patient will receive a good regimen to treat them. Okay, so hope you can learn something from today's lectures. See you 2 weeks later. I hope you can chat with me with your opinion, with your knowledge. Okay, see you 2 weeks 2 weeks later. Okay, hope your questions. Okay, thank you. Goodbye. Goodbye.